So, getting into our neurology, we're going to finish up here. We were talking about spongiform encephalopathy. Okay, so this is also known as Creutzfeldt-Jakob's disease. And what happens in Creutzfeldt-Jakob's disease is you have something called a prion. And a prion is an abnormally folded protein. So we'll say a regular protein looks a bit like this, and the prion, when it gets converted, looks a bit like this. Okay, now, this prion can get introduced into our system in any number of ways. We can have a surgery, like a brain surgery, that accidentally introduces one of these prions because the tools were not cleaned enough. We can have a blood transfusion that introduces prions. We can eat cerebral tissue from an animal that has a prion in it, and then this prion gets into our system. But however it gets into our system, what happens is we have one single abnormal protein, which is a prion, and this is going to rub up against our normally folded proteins, which ultimately gives us two prions. Okay, and now these two prions are going to go about and rub up against other proteins. So what ends up happening is the normal proteins in our body that do a lot of different things, especially in our central nervous system, end up getting converted into these abnormal, non-functioning prions. Okay, and so not only are these proteins not functioning and doing what they're supposed to do, they're also inducing the creation of other prions. Okay, and so in Creutzfeldt-Jakob disease, we see a rapid change and rapid onset of dementia. Okay, we should see a rapid onset. I'm talking over a course of maybe 3 months, with someone's personality changing, becoming more hostile. There's rapid onset of dementia, not remembering things. If you see that described in a question stem, and it's over a short period of time, please think of Creutzfeldt-Jakob's disease. Because when they describe these patients, they may try and trick you by describing more of an Alzheimer's or Huntington's disease type picture, where, especially Huntington's disease, you're having those behavioral changes, you're having dementia, right? That's sort of how we describe Huntington's disease. However, Huntington's disease takes a long period of time to develop, right? A lot of times it's an eventual thing, maybe over a course of 5 years, we're going to see changes. Versus in spongiform encephalopathy, Creutzfeldt-Jakob's disease, mad cow disease, right? In these diseases, it's very rapid. So if they start describing a patient with behavioral changes and dementia over a course of under a year, please think of this possibility. Okay. So it's associated with pituitary extract. So someone taking growth hormone, when we extract this part of the pituitary from another animal or another human being, if that particular animal or human being had prions, those prions are now in this new person's body. Okay. Corneal transplantation. So corneal diseases, cornea is the clear part on the front of our eye. Okay, so this is what the eye looks like. Here's how the light comes in. And so that clear part where the light comes into our eye is the cornea. Now, when we have some sort of abnormal pathology that causes the cornea to become opaque, or it doesn't allow light to get through, we may need to transplant a cornea from someone who has passed away. People that pass away, they donate their eyes to an eye bank, and those eyes can be used to remove the cornea and transplant the cornea onto a new person. Because the eye is considered immune privileged, where there's not a lot of white blood cells in the eye, you can transplant a cornea onto a new person without a high risk of that cornea being rejected. It's a very good surgery for these people. They go from not being able to see at all to being able to see 20/20. It's great. Now, the eye is considered part of our central nervous system, right? It's the one part of our central nervous system that we can actually see. And so, if there was prions in this patient who had donated their eyes, if that person had passed away because of a mad cow disease, then those prions are going to be present in the cornea. When we transplant this cornea, which is part of the central nervous system, that tissue may transmit the prions into this new patient. Okay, highly contagious. For surgery involving the brain, you really need to sterilize those tools, because that was how a lot of these prions were being spread, was through CNS surgery with tools that were not fully cleaned. Prions were being transmitted person to person. Okay? So spongiform encephalopathy is described this way because encephalopathy meaning it's involving the brain, spongiform meaning look at this histopathology image, if you will. You can see all of these vacuoles, all these big open spaces in the brain. This is very abnormal, and this is very typical for your spongiform encephalopathy. So just to recap, if they give you a patient with dementia and personality change is usually hostility, combativeness, wanting to fight people. If they give you those two things together, and it's over a very short period of time, and they give you a histopathology with a lot of big open spaces in the histopathology, please, please, please select Creutzfeldt-Jakob's, select Kuru, select mad cow disease. These are all variants of spongiform encephalopathy that is destruction of brain tissue due to abnormally folded proteins. Okay? Great. So here's another image where you can see really beautifully this vacuolization throughout the central nervous system tissue. Okay? Great. Multiple sclerosis, this is a demyelinating disease. Multiple sclerosis is an autoimmune disease where our white blood cells are attacking the myelin, which lines the axons in our central nervous system, right? When we have a nerve, we have the nerve body, we have this nice long axon, and then we have the dendrites where the signal is going to be transmitted to the next cell via neurotransmitters. Now, in order to pass this signal quickly through the axon, this area is going to be lined with these fatty white areas of myelin, okay? And by having this myelin, what happens is instead of the signal moving in a smooth fashion down the axon in a slow way, now the signal sort of jumps between these areas of myelin, okay? The signal can kind of jump along, so it gets down the axon much more quickly. And this is what enables us to have rapid reflexes. It's what enables us to really move, have motor control, really everything in our CNS system. This myelin is very important. So when we have white blood cells, our white blood cells attack this myelin sheath, it's going to break down that myelin, releasing some of the myelin into this cerebral spinal fluid and really creating areas where signals are not being transmitted in a nice way. Okay, signals may not make it to where they're supposed to go. They may take a long time. So, what are some of the symptoms of multiple sclerosis? Okay, so the first thing that I want you to know is that it is waxing and waning. Patients with multiple sclerosis will have a lot of symptoms as the immune system flares up and starts attacking myelin, and then their symptoms will sort of go away. As the myelin recovers, the immune system goes down, and then they'll have the symptoms again, and then it'll go away. Symptoms again, go away. So this waxing and waning course is very typical for multiple sclerosis, and it is almost always going to be described in the question stem. Okay, it's something I really want you to look for when they're describing this disease, is that the patient has had episodes of these symptoms throughout their life. Okay, so what are the symptoms? So number one that we look for, unilateral vision loss. You have a patient that presents with vision loss in one eye, blurry vision in one eye. She's a female, maybe younger. Multiple sclerosis is really one of the things you need to rule out. Okay. Other things that you can look for, dizziness, inability to speak, dysarthria, vertigo is giving us our dizziness. Our patients, a lot of times, because the signals are pain, itch, and temperature going through that spinal thalamic tract, that part is getting demyelinated, so these patients may have burns on their arms. Something I'd like for you to look for is on their arms or legs, usually the arms, I guess, they'll have burns from cooking. They place their hand on a hot stove and they don't realize it for too long, and now they have a burn on their hand. Okay, that should be unilateral because this demyelination is sort of random. As you can see in this image, these white patchy areas on the CT scan represent areas of demyelination, and it's not the same on both sides, right? I think we can agree that on either side of the central nervous system here, that the demyelination it's not the same on both sides, essentially. And so you may have a patient with a lot of burns on their right hand, but their left hand is unaffected. Why? Because the pain, itch, and temperature coming from that right hand, crossing in the spinal cord, at the level of the spinal cord, going up through the medulla, synapsing in the VPL, going to the sensory cortex. Somewhere in there, we have a demyelination. Okay? It didn't affect the left side, just the right side. Okay? So that's an important thing there, that it's not going to be bilateral necessarily. Another thing is that we can look for is motor weakness. Any nerve can be involved here. So motor weakness that is sort of involving certain parts of the body. These are all things that we can look for. Okay? On CT scans, this is going to be a very helpful way of diagnosing. What you're looking for is periventricular demyelination. Okay? And so you can see here's our ventricles filled with our cerebral spinal fluid, and you can see this is the area that's more involved than the rest of our CNS. Okay? For whatever reason, I don't know the exact reason that it is periventricular, but whenever you see the words periventricular demyelination together in a question stem, you are saying, thank you, Jesus, for sending me this question about multiple sclerosis. I'm going to answer it and move on to the next question. Okay? This is a very typical way of these patients presenting. Okay? Periventricular demyelination on CT scan. Okay? Treatment here, it is an autoimmune disease, and so, how do we treat autoimmune diseases? Steroids. Okay? We're going to give steroids and sort of induce a relapse into the, or a reduction in the activity of the immune system. And then as soon as the symptoms resolve, typically we're going to taper those steroids off, and because we don't want to leave patients on steroids for too long. Okay? That's our multiple sclerosis. We can see here, and these really nice images of demyelination right around the ventricles. You can see these big white areas, right? In the area of where the ventricles are. So that represents demyelination. Okay. So Alzheimer's disease, we're looking for an elderly patient, slow onset dementia, and it's going to be a global atrophy. So the entire brain is going to be involved here. When we talked about, our Huntingtons and, all these different diseases involving different parts of the brain, Alzheimer's is really going to be global. Okay, so we should see a shrinking of the gyri and largening of the sulci. So on a brain, the gyrus is the tissue that comes out. The sulci is the area in between. You can think of the gyri as the peak and the sulci as the trough in brain tissue. And so what we see is shrinking of the gyri. This area gets smaller, and widening of the sulci. This area gets larger. Why? Well, really, it's just because the gyri are becoming thinner. So it makes the sulci look larger in comparison to those, but that's sort of how we describe it. Okay? Great. So you can see here on these gross pathology images that normally when we look at a brain, it looks nice and plump and fatty and just full of tissue. This brain, to me, looks not like that. It looks like there's much skinnier, these gyri look much skinnier, and the sulci look quite wide. I mean, look at this brain, right? There's definitely something abnormal there. Alrighty? And so that's what we look for on gross pathology. We can look also, when we do our histopathology, for something called a senile plaque. Okay, and so a senile plaque is just simply a plaque of a bunch of proteins and tissues from a dead neuron that are, built into plaques. They are amyloid because whenever we have collections of proteins together that sort of start sticking together and staying there for a long time, we call that amyloid. When we stain it with Congo red, it's going to be positive. And if we look at it under ultraviolet light, what color are we looking for? With a positive amyloid on Congo red staining, we put it under ultraviolet light. What do we look for? Polarized light, excuse me. When we look on polarized light, what do we look for?
Black?
Yes, we look for apple green birefringence. Apple green. Okay, so this apple green birefringence is typical of amyloid. If you ever hear apple green birefringence, that is amyloid. Okay, so amyloid, again, it's just collections of proteins from dying cells. They stick around in areas, they don't get broken down, and they end up coalescing and causing issues. Okay, and that's what our amyloid is. Our neurofibrillary tangles is what we can see in this image here. These are tau-positive protein. What does that mean? Tau is a certain type of staining. So when we take a biopsy of a brain with Alzheimer's, and then we stain it with tau, which is the name of a type of dye, we see that it stains positive. Okay, so we call these tau proteins. And outside of these neurofibrillary tangles, we can see something called a Hurano-body, which are just these thick collections of broken down nerves, essentially. Okay. Patients with Down syndrome have a higher risk of developing Alzheimer's. There is a strong association there. Okay. And let's see what else we can say about Alzheimer's. Do you have any questions on Alzheimer's disease?
No, I'm okay.
Okay. So just sort of looking for a lot, elderly, dementia, and when we do a biopsy, we do see these tau bodies. And what has also been shown is that that the number of neurofibrillary tangles, it correlates with how severe the Alzheimer's is, how severe the dementia is. Okay, so these have some role in creating the pathology that we see. Okay, and just sort of as an aside, recently, just over the past few weeks or months, there was a research study done that used ultrasound technology to break up some of these plaques in a patient with Alzheimer's disease, and they were able to actually decrease the symptoms of Alzheimer's just using ultrasound technology, which I thought was very cool and something that maybe we'll be seeing used more over the next 10, 20 years. Okay. Probably not going to be on your step one, though, right? So here's another neurofibrillary tangle. You can see all of these tau proteins all around it with a concentrated core in the middle. Okay. Great. Okay. Here's another image with our tau positive, sort of with a different staining here. Another image that you can see describing Alzheimer's disease. Okay, now Pick's disease is something that we need to be able to differentiate from our Alzheimer's disease. So what we see in Pick's disease is atrophy. Just like we saw in Alzheimer's, we saw atrophy, right? We saw thinning of gyri, widening of sulci, just like Alzheimer's disease. However, in Pick's disease, we see those pathology only in the frontal and temporal lobe. Okay, and so when we look at this brain, you can see that comparing the frontal lobe to, say, the parietal lobe, I think you could agree with me that there is definitely some pathology going on here in the frontal lobe where the sulci look widened and the gyri look thinner. Okay? However, if we move to the parietal lobe, it looks like normal, regular brain tissue. All right? So, for Pick's disease, this is a genetic disease, and what we're going to look for in terms of symptoms are the things we would look for if we had a patient who lost their frontal lobe. Okay? And so lack of ability to plan, lack of sort of a filter in terms of what your patient is saying or how your patient interacts with other people. You can see increased sexual behaviors, really abnormal behavior for these patients because they lose that sort of, our frontal lobe is really important for executive functioning. And so in Pick's disease, when you have loss of that part of your brain, you're going to have someone who has loss of their executive functioning. Okay? Great. So if we do a biopsy of a patient with Pick's disease, we can see some eosinophilic lesions on biopsy. We call those Pick bodies. Okay, and so that's sort of all we need to say about this particular disease. Parkinson's disease, what we look for in terms of pathology here is loss of pigmentation of substantia nigra. So here's our substantia nigra right around the area of the medulla, and this is in a normal patient. You can see a lot of this nice pigmentation. And in this patient with Parkinson's disease, we see that that pigmentation is completely gone. This is going to be a question on your step 1 exam. This is going to be a question on your step 1 exam. You need to know that in Parkinson's disease, you have this really big loss of pigmentation in this area, okay? Why do we have loss of pigmentation of this area? Or what does this loss of pigmentation represent? What patients with Parkinson's disease have a loss of what type of neurotransmitter?
Dopamine.
Dopamine. Excellent. So
The cells that produce the dopamine are particularly that color. So when they start disappearing, you start losing the body cells.
Excellent. Yes, everything. So just repeating back what you said, with Parkinson's disease, we have a loss of the neurons that synthesize dopamine. Neurons that synthesize dopamine have this dark color to them, okay? And this just has to do with the entire pathway where we're taking tyrosine and ultimately converting tyrosine into dopamine, where tyrosine also gets converted into norepinephrine. It also gets converted to epinephrine. It also gets converted into what ultimately becomes melanin. And so because this tyrosine has all of these downstream things that can be turned into, you end up getting this very dark color to the neurons that synthesize it. And so what we look for is just that loss of pigmentation in the substantia nigra. And I promise you, Eva and Toby, if you're listening to this, you will have this as a question on your step 1 exam. You need to know this, okay? So treatment, we said that we like to give L-DOPA. We also like to give carbidopa. What is the job of carbidopa? Eva, can you remind me? I actually forgot.
Yeah, it's because L-DOPA it's converted, so inactivated in the system. So you need the carbidopa, so they block the enzyme, so you have more access in the brain.
Excellent.
Is that good?
Excellent, yes. So you explained that very well. I'm just going to repeat it back. So L-DOPA is replacing what our patient is missing. They don't have dopamine. L-DOPA is a replacement for dopamine. So that's great. L-DOPA can cross the blood-brain barrier and go to our brain where we really need it, but it also goes systemically, okay? And so, our whole body responds to dopamine. We have cells for dopamine all over our body, so it's going to be inactivated systemically, okay? Now, our patients don't need dopamine systemically. They only need it in their brain. So carbidopa, what it does, it cannot cross the blood-brain barrier. It can only stay in the system. So carbidopa will go systemically, and it will prevent the conversion of L-DOPA into inactive mediators systemically, okay? So all of this L-DOPA, the L-DOPA that was going systemic now is not being inactivated systemically, so most of it is going to cross over into that blood-brain barrier and cross over into the brain, and now we have more of it available, okay? Great. All right, and just so another histopathology, not histo, but gross pathology, really hammering home that you can see this big difference of color in the substantia nigra, okay? The other way that they ask you about this question is that they will ask you what is the primary neurotransmitter made in the substantia nigra, okay? And I want you to say dopamine, okay? Great. Huntington's chorea, we talked about Huntington's disease before. We said it is a autosomal dominant condition. It has anticipation, meaning through generations. Patients present earlier and earlier as these CAG repeats start to accumulate. This is in chromosome 4, and where we primarily see a problem is in the caudate. Okay, you can also see some in the putamen, but I want you to consider this to be a problem of the caudate. Now, in terms of our anatomy of the brain, we went over really sort of big picture anatomy, but I didn't really spend a lot of time telling you where a lot of these different structures are in the brain. I think we maybe did 5 minutes of me describing structures. One thing I always want you to remember, so we have these large ventricles in the brain. Our lateral ventricles are quite large. They're very easy to find on a CT scan, on our gross pathology, you can see a lateral ventricle here, you can see a lateral ventricle here. Now, on the wall of our lateral ventricle, this little balloon popping out right here is the caudate. Whenever you see a gross pathology or a CT scan and you see that lateral ventricle, I want you to imagine that whatever is pouching out into that lateral ventricle is the caudate. Okay? Just always remember that that makes up the wall of the lateral ventricle. Okay? And so we can see, comparing this normal brain with a brain with Huntington's chorea, that there is a complete loss of the caudate. The caudate should be pouching out here into the lateral ventricle. It is not, and that is because of this autosomal dominant condition. Okay? Great. Wernicke-Korsakoff, one thing that we can look for in gross pathology is the hemorrhage of mammillary bodies. So here are our mammillary bodies. They're described as mammillary bodies, right? Mammillary sort of means breasts, and you can see that they're kind of like pouching out here. I guess kind of like breasts. Whoever decided to name these had some weird sense of humor. And so you can see the mammillary bodies kind of pouching out here. In Wernicke-Korsakoff, we have hemorrhage there. Now, mammillary bodies are very important for transmitting signals to our hippocampus, which is important for memory. And so with the mammillary bodies having these hemorrhages, we are going to see some decreases in our patient's memory. We're going to see confabulation and things of that nature. Okay, great. So what's next here? We have our cerebellum in a patient with alcoholism or Wernicke-Korsakoff, and what this is showing us is just that it's a little bit shrunken down, a little bit smaller. Okay, and so our patients with long-term alcoholism, when we ask them, the typical test that we do is called finger-to-nose test, where you ask your patient to touch their nose and then reach out and touch your finger, and then you're going to move your finger into 4 spots, sort of creating a square, and then ask them to continue to move and keep touching their nose in between, and then reach out for your finger. And what you're going to see is that as these patients are trying to do this, they're going to overshoot your finger. They're not quite going to reach your finger, and there may be some tremors as they're attempting to do this. So cerebellum is really important for making sure. I'm sorry?
Coordination?
Coordination, yes, that's the word I was looking for, thank you. So coordination and making sure that when this patient is reaching out for that finger, that they are hitting that spot, okay? And so with loss of that, that's what we are looking for. Okay. Great, so moving into brain tumors here. What do we look for? Any patient with a brain tumor, we're going to look for headaches and seizures. That's sort of the typical thing we look for. Headaches and seizures. If there's an increased intracranial pressure, we can look for vomiting. That's especially severe in the mornings. When the patient wakes up in the morning, they're vomiting. That is sort of one of the red flags we look for. All right. Primary tumor is going to be a single mass. Metastatic, we would find multiple masses, typically at the gray and white matter. And we also talked before, remember that abscesses can also be found at the gray-white matter. So, this border here, I want you to really think about there being a lot of small capillaries there. And that's how you're going to remember any kind of bacteria, emboli that are going through the blood. This is where they're going to kind of get stuck into those tiny capillaries and where an abscess would start to form, at the border of the gray-white matter. Same thing for metastatic emboli. Here's where the capillaries are, and so it may get lodged there, and that's where the tumor will start to form if it's a secondary tumor, right? So typical metastases: breast, lung, GI tract, melanoma, and choriocarcinoma all go to the brain. Okay, great. First type we'll talk about is an astrocytoma. Astrocytes are cells that contribute to forming the white matter in our brain. If we have a tumor of a growth of one of these cells, we're going to see an enhancement of the white matter. Okay, and so you can see here just this large tumor mass. And the unfortunate thing about these astrocytomas is they sort of reach out into tissue. And so rather than having a nice encapsulated mass, we're going to have a lot of just fingers of this astrocytoma reaching into nearby tissue. So it makes them actually quite difficult to remove. Okay, and so we will see astrocytes. If this is in the posterior fossa, we call it a pilocytic astrocytoma. Okay, and so here on this brain biopsy, this is what the astrocytoma looks like. You will have questions where you need to have some idea of how these tumors look on histopathology. I'm not someone who usually spends a lot of time on histopathology, but in preparing for step 1, I had flashcards with images like this one, and that's all that was on the front of the card, and it said identify this CNS tumor, and then I would need to be able to identify from an image like this one what the tumor was. And I think that helps me on step 1. You will be able to, they'll give you some clues about it in the question stem to help you decide what type of tumor it is, but I really confidently will say that being able to identify these tumors off of histopathology will be a huge help for you on step 1, okay? And so you can go on Google, Google the name of the brain tumor and make some flashcards from the images you find. Make sure it's a good image. You can take the images from this lecture. I think they're very good images. I think step 1, first aid for step 1 has some really nice images in it of all the different tumors. If it's in first aid and they're wasting time showing you the histopathology, you have to know it's important, right? Because the retail space in there, right, the real estate, I should say, of that first aid book is very expensive. There's a lot of stuff that they try and put in there. And so if they're including something, you better know it. So I definitely think it's worthwhile to go through and memorize what the histology of these different tumors look like. Okay. Glioblastoma multiforme. Here we look for a butterfly lesion. Okay, I'm going to put a star by this because this is very typically described in the question stem. These butterfly lesions will cross the midline to the other side of the brain. Okay, and you can see here they're describing it as sort of a butterfly lesion because it does cross the midline, involving both sides of the brain. Okay, very deadly tumor here. This is not a resectable tumor because it's involving so much of that tissue in the white matter, and a lot of times you will see necrosis. When you do a CT scan, what you're going to see, if this is our brain, 2 lobes of our brain, we're going to see a ring enhancing. The edge of the lesion is going to be bright white. Why? Because it's necrotic. Okay, any kind of necrotic, anything necrotic going on in the brain is always going to be ring enhancing. Our abscesses, our toxoplasmosis, here our glioblastoma, all of these are ring enhancing because there's some necrosis going on inside. Okie dokie. Now, have a look at this histopathology. I think you could agree with me that this looks a lot different from our astrocytoma. A lot of times when I tell students you need to know this histopathology, it's like, oh geez, how am I ever going to learn this stuff? To me, this looks very different from that astrocytoma. Okay, so how do we describe this? We say it's pleomorphic with many different kinds of cells. That's not something that anyone but a pathologist would be able to identify. But what you do see is a lot of cells, right? There's a lot of cells very close together. And if you kind of squint your eyes, you can see that there's sort of a pattern here where you see a lot of cells together, a little bit of gunk in the middle, and then a bunch of cells on the other side. Whoops, hold on a second. And a lot of cells on the other side. And so what this is called is palisading around necrotic tissue. So you can see these big concentrations of cells are outside on either side of an area of a bunch of necrosis here and a bunch of just debris and gunk in the middle. Okay, and so that's very typical of glioblastoma. We said that this is a necrotic tumor, and so that's definitely consistent with what we see on histopathology. If you look down here, Eva, you can see another concentration of cells around an area of a lot of debris. So this would be another area of palisading. Okay. So again, to me, this looks very different from our astrocytoma. I'm going to go back to our astrocytoma and look at that really quickly, just so we can have a quick comparison. Where did it go? Hello, here it is. So here you can see that the cells are much more spread apart. There's a lot more white matter. Why? Astrocytes make white matter. Okay? Versus when we go to our glioblastoma, we can see just a ton of cells and a lot of necrosis inside. All right, so our next type here is our oligodendroglioma. On biopsy, what we see here is this idea of a fried egg cytoplasm. And so, if you look at these cells, number one, we see what kind of looks like an eyeball. Remember when we talked about orphan annii in our papillary carcinoma of the thyroid, right? We have our orphan annii and our somoma bodies, all those things for our papillary carcinoma of the thyroid. These cells always make me think of those orphan annii, right? Because we have this area of clearing in the cell and then a very diffuse nucleus. The nucleus is normally dark, nice and tight. Here, these nuclei are very spread out. There's areas of clearing inside the nucleus if you really look close and see. And so this always reminds me of that and it helps me remember oligodendroglioma. The cytoplasm of the egg white, nucleus is the yolk of the egg. You can kind of imagine how these look like fried eggs, right? Kind of makes you hungry a little bit. There's also this idea of chicken wire branching of capillaries, and so you can see sort of this branching of capillaries. I think that's a little bit harder to see. For me, the thing that always stands out is just this fried egg cytoplasm. Okay. All right, so again, this looks very different from the last two we looked at. Here, I don't see necrosis. I don't see, groups of cells clustering together. This is all, it's pretty diffuse, and the cells look very different. If you have a lesion involving the cerebellum, guess what? You have a medulloblastoma. Go on to the next question, okay? So here we're looking for gait problems. This is small round blue cell tumor, one of our PNET tumors. Here we can also see dancing eyes. Okay, so these PNET tumors are tumors that release norepinephrine and epinephrine. Okay, and so they can have a lot of different manifestations, but one of the things we look for is that these patients get nystagmus. Okay, so we're seeing a brain tumor with gait problems and nystagmus. Please select a medulloblastoma, especially if it's in a kid. Medulloblastoma, we said small, round blue cell tumor. This is why we call it that, because you just see tons and tons and tons of small round blue cells. Okay. These cells, I guess they could look a little bit like our glioblastoma multiforme. However, I don't really see any organization here. I don't see necrosis. Here, everything it's pretty diffuse, pretty random, just kind of these clusters, and you can maybe even see some rosettes of small round blue cells. Okay, and so you see a lot. This is a huge cluster of small round blue cells, and I think this is attempting to show some of the rosettes, although the rosettes are kind of hard to see. I think this is a rosette. A rosette, essentially, think of a rosette like a rose, where it should be circular. It should have a number of cells on the outside, like the petals of a rose, and maybe a cell on the inside, or a blood vessel on the inside occasionally. Okay, and that is a rosette. I think you might see one here. Looks a bit like a rosette. Maybe here looks a bit like a rosette. Here, maybe you can see a rosette. You really kind of have to have an artistic eye, right, to look for some of these things they describe. But that is the histopathology for this condition. Okay, meningioma. So a meningioma is a tumor of the meninges. So we're not talking about our CNS tissue itself here. We're talking about that connective tissue that's right outside the brain. This is a benign lesion. It compresses the brain but does not invade. Okay, we're not looking for metastasis. We're not looking for, these are not nerves or astrocytes or anything like that are growing, just that connective tissue cells that are growing. Okay, typically arises from arachnoid villi. That sounds important. Okay, so if you ever have asked where do meningiomas grow from, arachnoid villi, typically parasagittal. So right here, this is the most common area to have it, and this is associated with neurofibromatosis type 2. Okay, neurofibromatosis type 2. We also, in neurofibromatosis type 2, see tumors at the cranial nerve 7 and 8. Those patients have a lot of gait problems, hearing problems, because of those schwannomas around the cranial nerve 7 and cranial nerve 8. Okay. The other big thing we can look for here is our somoma bodies. Not too many conditions in the human body cause somoma bodies. Meningioma is another one of them. We talked about papillary carcinoma of the thyroid being another cause of somoma bodies, right? Okay, so whenever you see somoma bodies, that's sort of an easy thing. If they ask you about it, to get that answer right, is that you do see somoma bodies in meningiomas. These are going to be one of the easiest tumors to treat because it's not involving any of the CNS tissue here. So really, we can just sort of open up the calvarium, open up the skull, cut open this meninge, cut out the meningioma, close it up, and our patient's going to be good to go. It's benign, it's not involving, it's not metastasizing, it's just sort of growing and compressing. Okay, so the problem again is going to be identifying it because some of these tumors are very silent, but once we identify it, it's pretty easy to treat. Okay, so here, if you get a gross pathology like this, what I want you to look for is it involving CNS tissue? Well, when I look at this, I see CNS tissue completely going around the tumor, not involving the tumor. So if I were to see this, I see it's parasagittal, I'm saying that is a meningioma. That is a meningioma, okay? And so, you know, getting all this gross pathology, getting these images is really nice. It really makes you think, though, if this is so treatable, why is this person dead and donated their brain to science? You know, it comes to identifying them. They're very treatable, but we have to know that it's there. We have to correctly identify these symptoms in our patients so that we can get the correct scans and look for these things. Okay? All right, and so another image of our meningioma, showing some of our somoma bodies, fun stuff like that. Schwannoma, this is typically found at the cerebellopontine angle. And so this is a growth of our Schwann cells. Schwann cells contribute to what? Myelin. Okay, Schwann cells contribute to myelin. And so here we just have sort of a exorbitant growth of that myelin sheath. A lot of times we find it at the cerebellopontine angle. What is at the cerebellopontine angle? Well, that is where cranial nerve 7 and cranial nerve 8 are going to leave our brain and enter and sort of go through the auditory canal, external or internal auditory canal, and leave the inside of our skull. And so if we have a growth there, that may cause problems with our vestibular system and cause tinnitus. In neurofibromatosis type 2, we see bilateral neuroma, schwannoma in the acoustic area. Okay, so we're looking for that tinnitus, and we're looking for problems bilaterally in neurofibromatosis type 2. And again, they also tend to have meningiomas. Okay, great. Chiari 2 malformation is a congenital malformation of the skull. Okay, and so what happens in Chiari type 2 is that the cerebellar vermis, which is this lower part of the cerebellum, actually herniates through the foramen magnum, causing an obstruction of the aqueduct of Sylvius. Okay, so when we obstruct this aqueduct, we're going to end up having an accumulation of cerebrospinal fluid upstream. Right, cerebrospinal fluid is all synthesized in this area. This is where we have most of our arachnoid villi. Synthesizes lots of cerebrospinal fluid. That fluid is going to go into our lateral ventricles on either side. It's going to go up, and it's going to go all the way around the brain and really give us that protective area where any movement of the brain is sort of within this fluid-filled cavity. It's going to allow us to clear out some of the toxins and make sure the electrolytes in our neurons are at the right levels. And then eventually it's going to move down through the aqueduct of Sylvius into our spinal cord. We also have CSF in our spinal cord. That's how we're able to do a lumbar tap, lumbar puncture, is because it moves from these aqueducts into the spinal cord. Now, when we have this part of our cerebellum moving into the foramen magnum, it's actually going to compress that aqueduct of Sylvius and not allow the cerebrospinal fluid to progress downwards. However, cerebrospinal fluid is still going to be synthesized here in our arachnoid villi, and so the pressure in our intracranial pressure is going to increase. Okay. Other things that we can see in Chiari 2 include lumbosacral meningomyocele, which are associated with paralysis, sensory loss at or below the level of the lesion. What is a meningomyocele? What is a meningomyocele? So we have different grades for, okay, so let me start at what happens in embryologically. We have our notochord, which closes and will become the bone that encapsulates all of our nerves of our spinal cord. Okay, and then so this is what it's supposed to look like embryologically. Here's our notochord, here's our spinal cord inside, and we're going to have this nice closed off space. Now, in our meningomyocele, in our spina bifida, what happens is that our notochord does not close completely, okay? And so some of this spinal cord tissue, all of these nerves that's in our spinal cord, can actually herniate out of the bone of our spinal cord, of our spine, and actually be present at the level of the skin, okay? And so we have different grades for how much of that tissue herniates out. If none of it herniates out, but this area is open, typically what we will see is an area of hairy skin right above where that lesion is, and we call this spina bifida. Spina bifida. And all this means is that there's an area of the spinal cord where the bone is not completely closed. Maybe it's just a small gap, and it presents with this hairy area, but typically there won't be too many symptoms. Okay, just sort of that hairy patch, and it's usually in the lumbosacral area. Our meningomyocele, however, instead of just having this opening and nothing herniating out, some of our CNS tissue is actually going to herniate out and be present in a sac in the skin. Okay, and so now we have part of our spinal cord that is not enclosed within the bone of our spine itself. It is actually herniated out and is going to be enclosed within a sac that is visible at the level of the skin. Okay, that's our meningomyocele. Because all of these nerves are not protected by the spinal cord, a lot of times we're going to see paralysis, we're going to see sensory loss at and below the level of wherever that meningomyocele is. Okay, and so this is just sort of another one of the manifestations that we see in Chiari 2. We can see meningomyocele on its own, but yes, so that's sort of the worst possible condition. In the middle here, so between our spina bifida and our meningomyocele, you can just have a meningocele where you have an opening and you have a herniation of tissue out. However, the only tissue that's coming out is the meninges. The CNS tissue will still be encapsulated within the bone of the spinal cord. Okay, so we have our spina bifida, we have our meningocele, and we have our meningomyocele. It's sort of the worst possible case of what you can get. Any questions on that?
No, okay.
Okay. Great. So that is it for our neuro section. I'm going to discard my ink annotations. And we are going to move now and do a quick review of strokes. Okay? And I think that my stroke PowerPoint is really just something great because you are going to definitely get a lot of questions on strokes for step 1, and so I want you to be comfortable with the most common things you can be asked about for strokes. Where are we? So let's share. We have strokes here. Okay. Okay, so this first image I wanted to show you because this is actually a patient that I saw during my surgery rotation. Okay, I took this picture of a CT scan of a patient that I saw during my surgery rotation. And so I like to ask just sort of, what do you see when you look at this image? Do you see any pathology? If so, where do you see it? And what do you think is happening? No wrong answers, just whatever you see, let me know.
I see that it's not the borders, you know, it's not, how do you call it? It's not circular.
It's not circumscribed, right?
Circus, yeah.
Good.
That.
Good. So, so what side of the brain, just sort of like, explain it to me like I'm 5 years old, what do you see here?
That must be right side.
This is the right side, excellent.
Mm-hmm.
Okay. And the area that you're talking about is here, correct?
Mm-hmm.
Okay, good. Now, what do you think of this here? You can see that there's something there that is not present on the other side. So what do you think happened here?
It looks like bleeding.
Bleeding, right? Good, excellent. So, so I'll just tell you what happened with this patient is that this is a patient who was a long-time smoker, a long time chronic hypertension, and not taking his medications. And he went outside. He was actually visiting a family member that was in the hospital. He said, "I'll be right upstairs. I just want to go smoke a cigarette before I go upstairs." Right? You're at a hospital and you want to smoke a cigarette, whatever, no judgment. And he stepped outside to smoke a cigarette. He pulled out his pack of cigarettes, and then all of a sudden he fell backwards and then struck his head on the right side here. All of a sudden, he pulled out his pack of cigarettes, and then all of a sudden he fell and struck his head on the right side. So, our assumption of what happened here is that we talked about how patients with hypertension, there's an artery in our brain called the middle cerebral artery, and that middle cerebral artery gives off a bunch of tiny little arteries called lenticular striate arteries, right? And what can happen is that we can get tiny little aneurysms in these lenticular striate arteries. And we call these Marie or Charcot-Bouchard aneurysms, okay? And when you have a little aneurysm here, you're going to have a little bit of loss of tissue, and we call those lacunar areas, lacunar strokes, essentially. Lacunar strokes, right? Just the area around the aneurysm where we don't have any tissue, okay? But an aneurysm is just a swelling of a vessel. An aneurysm by itself typically is not going to have a lot of symptoms. Now, when you have a patient that has this high pressure blood passing through for a long period of time, this high pressure blood being transmitted into these thin walls of these little aneurysms, what's going to happen? They're going to burst, okay? And so what we think happened in this gentleman is that he was essentially a ticking time bomb. When he reached down for his pack of cigarettes, right at that moment, one of these little aneurysms burst, and now you have frank bleeding into the parenchyma or into the CNS tissue of the brain, okay? And so by the time that, so he fell, causing this contusion on the outside, not necessarily related to the bleeding inside, but this sort of happened afterwards. And so by the time we got him inside and got the CT scan, you can see that from this tiny little artery, we already have bleeding comprising almost, it looks like about 20% of the CNS tissue, right? If we broke this down into fifths, I think you could agree that this is almost 20% of this patient's brain is now basically going to be necrotic because of this hemorrhage. Okay, very, very scary, very, very scary. And so this is sort of what I want you to look for if it is an intraparenchymal stroke. This patient is bleeding into the parenchyma, into the tissue of his brain. This is how it looks. Okay, I'm going to, can I erase all this stuff? Okay, great. So this is what I want you to look for with intraparenchymal strokes. Just this non-circumscribed, like you told me, area of hyperintensity or whiteness, right? It's much brighter than the rest of the tissue around it. This is a hemorrhagic stroke. Okay, great. So let's get into strokes here. Here is our circle of Willis. I promised you that I would show it to you in greater detail. Here it is for you. And so this is our circle right in the middle. The arteries that make up, the major arteries that make up the circle of Willis, we have the middle cerebral artery, which is formed from a continuation of the internal carotid artery. So the internal carotid is one of those arteries that goes through our neck and ultimately gives off our middle cerebral. The first branch of the internal carotid is our posterior communicating artery, which is going to give off our posterior cerebral artery, giving all of our blood supply to the occipital lobe and what we discussed before. From the posterior cerebral artery, the other contribution to that is going to be our basilar artery, which is an anastomosis of our two vertebral arteries. Okay, so our two vertebral arteries are going to move up through our spinal cord. They're going to synthesize together into one large artery called basilar artery, which is going to branch once again, giving us our posterior cerebral. Okay, basilar artery is important for other things besides just our posterior cerebral. You can see that it gives a lot of branches to our cerebellum. Okay, and we're going to talk about strokes in our superior cerebellar, our anterior inferior cerebellar, our posterior inferior cerebellar. Strokes in any one of these arteries is going to present in a different way. Okay. Moving back up to the front of our circle of Willis, we have a branch moving from the middle cerebral, which is our anterior cerebral artery. It branches right off the middle cerebral, and it's going to give all of that blood supply to the parasagittal region, right? A stroke here means we would lose motor and sensation to our legs, versus in our middle cerebral we would lose more motor and sensation to our arms and our face and all the stuff we talked about before with strokes. And we also have the ophthalmic artery, which is pretty important for being able to see stuff, right? Last is our anterior communicating artery, which we said is the most common location for a berry aneurysm, right in this area. Okay. So this is our circle of Willis. Be able to sketch one of these quickly if you are asked to identify, if you are asked to label this in a diagram. The ones that I really want you to focus on are all of these cerebellar branches. These are the ones they're going to ask you about, right? Everybody knows middle cerebral. Everybody knows posterior cerebral. Those ones are obvious. What I want you to know is where's the superior cerebellar? What is the name of this large artery that's formed from the continuation of our vertebral? Which artery is this last branch? Okay, and so this area here I think is more high yield in terms of labeling, and I really want you to know what these are. Be able to label this from a blank diagram. Be able to label it from a gross pathology. When they're just giving you the arteries of some dead guy, be able to label it from that as well. Okay, great. So our middle cerebral artery. What do we look for in terms of a stroke here? We have our motor and sensory cortices. So like you told me when we talked about this on Monday, a stroke here would lead to problems in the upper limb and face, because those are represented in the motor in that area that's supplied by the MCA. Our temporal lobe is also supplied, so that's our Wernicke's area, our frontal lobe, so our Broca's area. Those could both be involved. Maybe one of them is involved, maybe both, maybe neither. Depending on how severe the stroke is, we'll tell you how bad the pathology will be. This is going to be contralateral paralysis and sensory loss, right? If we're at the level of the cerebral cortex, right? So here's our cerebral cortex, here's our thalamus, here's the medulla, here's our spinal cord, and here's our hand. Okay, so if we have a stroke in the left MCA here, well, that is all going to be sensory information that has either decussates at the medulla, synapses in the thalamus, and then synapses here, so that would be contralateral, or it could be our spinothalamic pathway, which decussates at the spinal cord, passes through the medulla, synapses at the VPL, and then synapses again here in the in the cerebral cortex. So that would be contralateral. In terms of motor, motor comes down, it's going to decussate at the medulla, and then it's going to synapse in the anterior horn of our spinal cord, giving us our lower motor neuron here. So again, everything is going to be contralateral. When you have a stroke in the MCA, all of the symptoms are going to be on the opposite side of the body. Okay? We also said, I don't want to leave things out, so we also said if we had a stroke at the thalamus, everything would also be contralateral. Okay? So those are two cases where you're going to see all of your symptoms being contralateral. It's in the thalamus or in the cerebral cortex because everything has crossed over at that point. All right? Now, if we're involving our dominant hemisphere, we can look for those aphasias. So our Broca's aphasias, Wernicke's aphasia. If it's in the non-dominant hemisphere, then we look for hemi-neglect. Okay, we say, okay, sir, we know you had a stroke, but we think you can go home now if you can just go ahead and put on your jacket. This patient is going to go ahead and put on one sleeve of their jacket and say, okay, bye, doc, and just walk out the door with only one sleeve of their jacket on. Why? They have hemi-neglect. Involvement of their non-dominant hemisphere leads to hemi-neglect. We're going to ask this patient to draw a clock. Okay, they're going to go 1, 2, 3, 4, 5, 6. Okay, that's one clock for you. Thank you very much. I've completed my work. Okay, they've neglected this entire side of the clock. That's hemi-neglect. That is our non-dominant side. Okay, great. Anterior cerebral artery, looking for motor and sensory cortices of our lower limb, contralateral paralysis and sensory loss of the lower limb. And you can also have involvement of the ophthalmic artery, giving you vision loss on one side, which would be the same side as the stroke, of course, because that's the eyeball that gets the blood supply. All right, our lenticulostriate arteries. Okay, so lenticulostriate arteries, these keep coming back again and again, right? So here's our middle cerebral artery. Here's our lenticulostriate arteries, these tiny little arteries that go up into the striatum and internal capsule. Okay. And internal capsule, what are these things important for? So the internal capsule is essentially like a highway. It's carrying a lot of motor information down from the motor cortex and towards the thalamus and the medulla and all that area. It's also carrying some sensory information up towards the sensory cortex. This is like a highway. And so that's why we make sure that we have these lenticulostriate arteries to supply this highway. All the nerves, all the axons that are passing through here are going to have plenty of blood supply and be able to transmit signals quickly. Now, the problem here, and why we see so many, why we talk about lenticulostriates so often, I feel like I'm a broken record now, but we can have these Charcot-Bouchard aneurysms here, giving us those lacunar strokes, and if it's severe enough, we can actually start to have hemorrhage. But if it's just a lacunar stroke, that is just going to cause an area of small ischemia. And so what we would look for is contralateral paralysis, sensory loss of the face and body. However, we're not going to see any of the cortical signs. So neglect, aphasia, visual field loss. The only information in the internal capsule is sensory information and motor information. Okay? So here's our first chance to really build a dichotomy and build the difference between different types of strokes. We said when we have a stroke of our MCA, that is going to give us contralateral paralysis. It's going to give us contralateral sensory loss. It's going to give us symptoms of aphasia, symptoms of hemi-neglect, right? So we have cortical signs and we have paralysis and sensory signs. However, if the stroke is in the lenticulostriate arteries, we're going to have that contralateral paralysis, we're going to have contralateral motor, however, no cortical signs. No visual field loss, no aphasia, no neglect. Okay? So this is your first chance to build that differential and get the question right. You have a patient that presents with this motor and sensory loss, right? That's how the patient's being described as contralateral, and so you're Eva and you're saying, okay, I know that when it comes to completely contralateral, I can have a stroke in the MCA, I can have a stroke in the ACA, I can have a stroke in the thalamus. I can have a stroke in the lenticulostriate arteries. So I know those are my 4 places. Now, I'm now going to look for signs of cortical stroke. If I see cortical stroke, I'm going to go more towards MCA, ACA. If I don't see any signs of cortical stroke, I'm okay picking lenticular striated arteries or thalamus. Okay? Great. So common location of lacunar infarcts secondary to unmanaged hypertension. Okay? Which we're comfortable with that idea now. Alrighty? Great. So our anterior spinal artery. So our anterior spinal artery is here. It's not labeled, but it is the artery that is the first branch of the vertebral artery coming down into the spine. It's going to travel down on the anterior part of our spinal cord. So if this is a bit of our spinal cord, all right, there's our anterior horn, our posterior horn. Okay, great. And there's the canal. Our anterior spinal artery is going to be right here in the front, and it's going to be contributing to blood supply to 2/3 of our spinal cord. Okay? So, if we have an infarct there, we're looking for a loss of our lateral cortical spinal tract, our medial lemniscus, and our caudal medulla. Okay? So what is that going to look like? A contralateral paralysis of upper and lower, decreased contralateral proprioception because of loss of our medial lemniscus, and ipsilateral hypoglossal dysfunction. That means the tongue is going to deviate ipsilaterally. When it comes to lesions in our hypoglossal nerve, what we look for is for the tongue to go in the direction of where the lesion is when we ask our patient to protrude their tongue. Okay, so when we have our patient, we're going to say, stick your tongue out, please. Okay, so for a regular patient, they have muscles on the right side, they have muscles on the left side, and those muscles push the tongue forward. If we had some sort of infarct on one side of the nerves that provide stimulation to those muscles, what's going to happen is the other muscles are going to kind of win out and push the tongue in the opposite direction. So when we have a hypoglossal infarct, what we see is that the tongue is going to deviate in the direction of where the lesion is because we only have muscles working on one side, right? So that kind of makes sense. If the muscles on this side of the tongue are stronger than the muscles on the other side, then this side is going to win, is going to push in the opposite direction. Okay? So tongue, the way we think about this is that we lick our wounds. We lick our wounds. Whenever we talk about a lesion to the hypoglossal nerve, whatever direction the tongue goes, when we ask our patient to stick out their tongue, is the direction or the side in which the infarct is. Okay? And so here we can talk about our medial medullary syndrome. This is an infarct of the paramedian branches of the anterior spinal artery and or the vertebral arteries. Okay? So those all supply the middle part of our medulla. And so medial medullary syndrome, look for all of these factors together. Look for a tongue deviation, loss of proprioception, contralateral paralysis. Okay? This is a pretty straightforward and simple one. This one I would not say is terribly high yield. You won't get many questions on medial medullary syndrome. What they will ask you about is our lateral medullary syndrome, which we are getting into on this slide. So our PICA, posterior inferior cerebellar artery. Let's go back to our circle of Willis and look at where that is. So here we go. We're down here at our posterior inferior cerebellar artery. This is providing blood supply to the lateral part of our medulla. What's in our lateral medulla? Well, we have vestibular nuclei. Vestibular nuclei are important for our ability to maintain our being upright, or maintain our position in space. Lateral spinothalamic tract, okay, so that's our pain, itch, and temperature, right? Spinothalamic is pain, itch, and temperature from the opposite side of the body. We've already crossed over. Spinal trigeminal nucleus. What is the trigeminal nerve important for, Eva? Can you tell me? What does the trigeminal nerve do?
Innervates the muscles of, how do you say masticación?
Okay, yep, chewing.
Mastication.
Mastication is our medical term for it, right?
That's one.
Yep, so muscles of mastication, what else?
And I'm not sure, and I don't remind all the details.
No problem.
It's better if you say it. That's all right. Take it.
Okay, so here's me wearing some glasses. I normally wear glasses. I don't like to wear glasses when I'm tutoring though. So here's me wearing my glasses. Here is my spinal trigeminal nucleus. And what is the information that's coming to our spinal trigeminal nucleus? Here is our thalamus. We have our V1, we have our V2, and we have our V3. Okay, so V3, V1, or V2, and V1. These are all sensory nerves. Okay, so here's our sensory nerve body detecting any sensation from my face, and that axon is going to synapse in the VPL or VPM of our thalamus. Which part receives sensory from the face? We talked about the nuclei of the thalamus. We said that there's a VPL, which receives sensory from one, I almost gave it away. VPL receives one type of sensation from the body. VPM receives another type of sensation. Our VPL, I said L stands for limbs, right? And VPM, what does the M stand for?
No, I don't remember right now.
M stands for makeup.
Makeup, so it's face.
So it's face, excellent, good. So our V1 is going to transmit all of the sensory from the upper part of our face to the VPM of our thalamus, okay? From there, that sensation is going to go to the spinal trigeminal nucleus, okay? That's in the medulla. V2, any sensation from the middle part of our face, from our nose to our upper lip, all of that sensory information, again, is going to synapse at the VPM, and then that next nerve is going to go to the spinal trigeminal nucleus, spinal trigeminal nucleus. V3 is all of our lower part of our mouth, again, VPM, again, to the spinal trigeminal nucleus, okay? So, if we have a loss of our spinal trigeminal nucleus, we have a loss of ipsilateral, same side, sensation from the face. There's a rule when it comes to cranial nerves. Cranial nerves is cranial nerve 1 through cranial nerve 12. They do not decussate. They do not decussate. So when we talk about our spinal trigeminal nucleus being all of our sensation from the face, if we have a loss of that nucleus, that is going to be information from the same side of the face. Okay? That's different from sensory from the body, right? If you think about having a, let's just talk about the thalamus, right? So we have our VPL here, and we have a VPM here, okay? VPL is getting all of our sensation from the body, VPM from the face. Now, here's our right side of the thalamus, here's the left side, okay? I am going to take a samurai sword, and I'm going to chop out this part of the thalamus, okay? Now, when we lose this part of the thalamus, we are losing all of our sensory from the opposite side of the body, right? We said that all of our sensory nerves decussate before they get to the thalamus. So a lesion in the thalamus means losing contralateral pain and temperature, contralateral fine touch, proprioception, all of that has crossed over by the time we get to the thalamus, okay? Now, when we talk about our VPM, however, when we lose that same side VPM, this is all from the same side. All of our pain and temperature and fine touch from our face stays on the same side. It does not decussate. Why? It's a cranial nerve. Cranial nerves do not cross. Cranial nerves do not cross. When we talk about our facial nerve is going to provide a lot of motor to our face, right? It's going to allow us to smile and frown and make different movements of the muscles of our face. If we lose our facial nerve, that is going to be reflected on the same side, okay? It's a cranial nerve, so that means same side, all right? So when we see decreased pain and temperature sensation from the ipsilateral face and contralateral body, I want you to think about pica. I want you to think about this posterior inferior cerebellar artery, which is providing blood supply to our spinal trigeminal nucleus and the lateral spinal thalamic tract. Okay? What we call this is our lateral medullary syndrome, aka Wallenberg syndrome. But But I really want you to start thinking about if you have a patient who, if I can draw my patient here, we have a patient who has a loss of sensation from one side of their face and a loss of sensation from the other side of their body. I want you to start thinking about this pica, P-I-C-A, and our lateral medullary syndrome. Okay? So, with this man I just described, or this man I just drew, we see that on his left side of his body, he's lost all of his sensation. I'm sorry, on the left side of his face, he's lost sensation, and on the right side of his body, he's lost sensation, right? So if it's right side of body, left side of face, this should be on the left pica, right? Because spinal trigeminal nerves do not cross over. So we know if it's involving the trigeminal nerves on the left side of the face, it must be a left-sided lesion, okay? Great, so does that idea make sense to you? Does that sort of seeing this dichotomy of one side of the face and the other side of the body and why that is?
Yes.
Good. Okay, so I'm glad that makes sense. And hopefully you're starting to associate that with this lateral medullary syndrome. However, I have a little bit of bad news that you also see that in a couple other syndromes that we're going to talk about next. However, what's special about our lateral medullary syndrome, and this is one that you're going to get a lot of questions about, is that you see lesions in the nucleus ambiguus, which is our vagus nerve. So that's going to give us dysphagia, hoarseness, decreased gag reflex. Okay? So we see our man with one side of face, one side of body, and we see dysphagia, hoarseness, decreased gag reflex. Those two together means it's lateral medullary syndrome. These nucleus ambiguous effects are specific to pica lesions, meaning I want you to look for one side of face, opposite side body, plus this difficulty swallowing, this hoarseness of the voice, decreased gag reflex, okay? It's gotta be those together, okay? Why? Because we lose this nucleus ambiguous, and we lose sympathetic fibers, giving us a Horner syndrome, and we lose vestibular nuclei. We should see some vomiting, vertigo, nystagmus. The problem with learning these strokes is that some of these things are in common with different syndromes, and so the important thing for you is to memorize the things that stand out the most and memorize the things that are specific, okay? So for me, when I was learning this, the things that stood out the most is one side of face, one side of body. When I saw one side of face, one side of body, boom, that already narrowed me down to about 3 different diseases, okay? Now that I've narrowed it down to those 3, now I'm looking for these nucleus ambiguous effects. I'm looking for difficulty swallowing, hoarseness, lack of gag reflex. When I see that, I say, thank you. That is a lateral medullary syndrome. This is because of the PICA. On to the next one, okay? On to the next question. Okay? Good, 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 good. Let's move to the next one, and you can see what I'm talking about. So we said we have a PICA. Now we're going to talk AICA. So before we get into it, let's look at our circle of Willis. Posterior inferior cerebral we just talked about. This is our one side face, one side body. This is our nucleus ambiguous, giving us dysphagia, hoarseness, decreased gag reflex. Vestibular nuclei is involved. We're going to have vomiting. We're going to have nystagmus. And we're going to have some Horner syndrome as well. Okay, so that is all of our PICA if we have a lesion there. Now we can move a little bit further up and talk about our anterior inferior cerebellar. Okay, so let's see what happens here. With anterior inferior cerebellar, we're going to be involving the pons. Okay, we call this as lateral pontine syndrome. So what does it look like? Well, in our pons, we have cranial nerve nuclei for our vestibular nerves, our facial nucleus, our spinal trigeminal nucleus, and cochlear nucleus. Okay, and then I know what you're thinking already. Whoa, whoa, whoa. You just told me that the vestibular nuclei and the spinal trigeminal nuclei are from the PICA. How is it also in the AICA? How does that make sense? Well, when we look at the medulla, medulla looks a bit like this, right? When we look at the medulla, we really look at it from a top-down point of view, and we say, oh, we have one nucleus here, one nucleus here, one nucleus here. That's great. So if we lose our blood supply to this area, we're going to lose these 3 nuclei. However, we need to think about this more in a 3-dimensional way. So rather than a nucleus just being this small flat spot, if we look at our pons and medulla from a side view, okay, so there's our pons and here's our medulla right below it, so these nuclei actually are vertical, okay? And so these nuclei are vertically oriented next to each other. So these 3 spots correspond to these 3 spots. So if we lose blood supply in our PICA, yes, we're losing blood supply to these nuclei because at that level we lost blood supply. But how about our AICA? Well, there's still, these nuclei are vertical, so we still lose some blood supply to those nuclei, even though it's at a different level. So here's our AICA, here's our PICA. So I want you to think about the fact that when these nuclei are vertically oriented, okay, they kind of continue on in a vertical fashion, so a lesion in our pons can have similar effects to a lesion in our medulla, because these nuclei, they don't look at their zip code. They don't look at the address. They just sort of live wherever they want to live. And that means that they're going to be vertically oriented and they're going to live in the pons and the medulla, and they're kind of going to progress through each of them. Okay? Great, so moving on. So since we said vestibular nuclei, we're going to look for the same thing that we saw in our lateral medullary syndrome. We're going to look for that vomiting, vertigo, nystagmus. Okay, this is getting a little more confusing, right? Because it's the same thing in both. So we need to find something that's different between our AICA and our PICA. What is different, okay? So facial nucleus, boom, there it is. When we talked about our lateral medullary syndrome 1 slide ago, and we talked about Wallenberg syndrome, did we say anything about facial nucleus? Did we say anything about paralysis of the face, which is what a lesion there would be? No. We said we have loss of sensory of the face, right, because of our trigeminal nucleus, but we said 0 about our motor to the face, okay? And so this is going to be our way of knowing that this is an AICA, not a PICA, okay? AICA causes paralysis of the face on the same side. Paralysis of the face on the same side. Because our spinal trigeminal nucleus is involved, I also want you to look for our man with 1 side face, 1 side body. Okay, so here's our man. Here's 1 side face we're going to lose because of that spinal trigeminal nucleus. And then we're going to lose the other side of body. Why? Because it's also involving our corticospinal tract. Okay, corticospinal and spinal thalamic. So spinal thalamic is our painage and temperature from the body. And so we're going to lose all of that, just like in our Wallenberg syndrome, in our lateral medullary syndrome, we had same side face, other side body, right? We had that. Same thing here. But what are the differences? So here in AICA lesions, we see paralysis of the ipsilateral face. If you see 1 side face, 1 side body with paralysis of the face, I want you to pick AICA and move on to the next question. Okay? If you see 1 side face loss of sensation, 1 side body loss of sensation with dysphagia, decreased gag reflex, coughing, I want you to pick PICA, lateral medullary syndrome. Okay? That's how we're going to differentiate these two, and that's how you're going to get these questions right. Facial nucleus effects, that paralysis, are specific to AICA lesions. Okay? Facial droop means AICA is pooped. All right? Now, you need to see facial droop with all this other crap, right? Right? Not facial droop by itself. Facial droop with all of these other symptoms: vomiting, vertigo, nystagmus, sensory changes, all this other stuff is what's going to give you that. Okay? There's other things here that you're also going to lose because of your middle cerebellar peduncles. Is going to give you your ataxia, dysmetria. Trying to memorize all these things is really a fool's errand. I want you to memorize what is special about these. Okay, for me, what's special about it is we have these sensory 1 side face, 1 side body with facial paralysis. Okay, I memorize those 2 things. I memorize that it's involved in the pons. I memorize that it's AICA, and that's it. That's all you need to know. Basilar artery. So basilar artery is involving a lot of very important nuclei. Don't really worry about what exactly it's involving. What I want you to know is locked-in syndrome, which is where you have consciousness, vertical eye movement, and blinking. However, that's pretty much the only movements that your patient can make. They can move their eyes up and down, they can blink, and that's it. Okay, very, very sad. Very, very sad. This is a lesion in our basilar artery. I'm going to move back to our circle of Willis. We can look at where that is. So our basilar artery is right here. So loss of all of this stuff. We're losing our pons, we're losing our medulla, we're really losing everything. The only thing we're still going to have the ability to move is our eyes up and down, not even left and right, only up and down, and we'll be able to blink. It's called locked-in syndrome. Okay, very sad. But that's all you need to know, which is very happy. Okay, and that is it for strokes. That is it for strokes. You will see other strokes described, even in first aid. I really think that spending the time to memorize the few that I've just gone through with you is really going to be the most worthwhile way for you to spend your time in learning strokes, because those are the most high yield, and if they're not one of the ones that I described that you're being asked about, then you can probably eliminate your way to the correct answer. Okay, you know what to look for with Wallenberg syndrome, lateral medullary syndrome, same thing. You know what to look for. You know what to look for with pontine syndrome. You know what to look for with an MCA stroke, with contralateral paralysis, contralateral loss of sensation, Wernicke's syndrome, Wernicke's aphasia, Broca's aphasia, and possible hemi-neglect, things of that nature. Okay, you know what to look for with MCA. You know what to look for with ACA, where you're having contralateral loss of sensation and motor to the lower body. Okay. All right, great. Any questions on strokes before we move on to our microbiology?
I'm okay.
You're good? Okay, good. Good. Did I cover any questions that you had on strokes? Because this is a topic that I get a lot of questions on.
I have seen many questions about it, but I think now with this I can nail it.
Okay.
I have to remember all the nucleus and which one is involved in what action. So I
see.
I can narrow that. Yes, and it's like you said, and the more practice, you are going to remember and associating, or by the scarf, say, well, I know these are not.
Yes, elimination is key. Good. Yes, in terms of learning all the nuclei, neurology is a very, very expansive topic, and you can spend a long time diving deep into learning the things. I didn't do that. I really tried to focus on what's going to be the most high yield for me, and so I want you to learn what's relevant. Okay, and I didn't spend time talking about the different cranial nerves and what they do. Cranial nerve 2 is this, cranial nerve 3 is that, oculomotor, trochlear, trigeminal. I didn't spend time doing that because you can memorize that stuff on your own, okay? And you should definitely spend time doing that. The other thing I think you should know is which of the cranial nerves provide sympathetics. Okay, so parasympathetic travels with some of the cranial nerves, and so memorize which ones carry parasympathetics, okay? Okay, great. So that is it. We can move on now into microbiology. I think we're having a very productive day so far. Finishing 2 lectures has to be a first. Let's see here, moving into our microbiology. Eva is topping up her yerba mate because she knows that micro is a not exactly fun topic, right?
Well, I actually like it.
You do? Okay. All right. Well, that makes one of us. No, micro is fun. Micro is fun. There's a lot of cool stuff to see, a lot of cool stuff to learn here. We're going to go through the different organ systems and talk about what are the most common infections in each. The way that I organize this lecture is through using charts. I love using charts for microbiology because you can see everything right next to each other. And what's helpful is covering up parts of the chart when you're trying to study with this. If you printed these out, Eva, I think that's a very smart idea, because you can just take a blank piece of paper, cover up all of, so let's just look at this chart for example. You can cover up everything from about this line down, cover everything, and just guess. Okay, so we have adenovirus. What kind of virus is it? What's the reservoir? How do we detect it? What are the clinical indicators? This is most important, right? And do that for everything on this chart, and oh my goodness, you are going to be in a really good spot when it comes time to answer questions about these, because everything on this chart is fair game. Okay, so let's go here. Upper respiratory tract. When we talk about upper respiratory tract, pharyngitis is simply an inflammation, erythema of the pharynx. Okay, so we can describe this as a sore throat or adenophagia. We may, in some of these infections, see an inflammation of our tonsils. If we see exudate, usually we think bacterial, although the classic example of that is going to be our infectious mononucleosis. We also see exudate on the tonsils. Laryngitis, inflammation of our larynx and vocal cords, giving us a hoarse and raspy voice. Okay, so whenever we say pharyngitis, we're describing all of these things. All of these things are fair game. So let's look at some of our most common, our usual suspects here. Okay, so in terms of our viral etiologies, we're really, the load is going to be carried by our adenovirus as well as our Coxsackie virus. Adenovirus is probably more common than anything else. Adenovirus is a double-stranded DNA. It is naked DNA. So what do we mean kind of generally when we say something is a double-stranded DNA? What is the relevance of that?
They have two sides, so it's not half of the DNA, it's two copies.
Yes, exactly. So when this virus infects our cells, a viral capsid doesn't have the ability to synthesize its own DNA. It relies on our cells. That's the thing. So virus is going to have a bit of DNA with it. It may have a few enzymes in here, but typically all viruses are going to have a bit of DNA. It can be double-stranded DNA. It can be single-stranded DNA. It can be double-stranded RNA. It can be single-stranded RNA. Okay, so the virus is going to land onto one of our cells. It's going to inject its contents into the cell. What happens next is really one of the most important things for us to understand, and one of the things that we can get a lot of questions about. Because depending on the type of nuclear material in this virus will determine what the next step is. Why is that? Well, our cells are trained to recognize things like free-floating DNA, free-floating RNA, and destroy them when they see them. Our cells do not like seeing these free things floating around, and it will destroy it if it sees it. Okay, and so for a double-stranded DNA virus, for example, once it injects this bit of DNA, it's going to want that DNA to go straight to the nucleus. Okay, once inside the nucleus, our cells are used to seeing double-stranded DNA, right? That's what our chromosomes are completely composed of. Double-stranded DNA. We have one strand with a bunch of nucleotides bound to another strand with a bunch of nucleotides. Okay, and so when this virus comes in here and injects a little bit of this exact same stuff, our cell says, "Oh, you know what? I know double-stranded DNA. I love double-stranded DNA. I've been looking at this my whole life. I'm going to start turning this stuff into messenger RNA." Okay, so the virus is able to use our own machinery, our own enzymes, our own polymerases to convert the viral chromosomal material into an mRNA strand. Okay, now our cells again are used to seeing mRNA. So this little bit of mRNA strand is going to go out into the cytosol, and what's going to bind to it? Ribosomes. Ribosomes are used to seeing mRNA. Say, I've been looking at mRNA my whole life. I know what to do with this stuff. I'm going to take this mRNA, I'm going to convert whatever it codes for into a protein, and I'm going to do my job because I know mRNA. Me and mRNA go way back. Okay, so now the virus again is able to use our own machinery, our own proteins and enzymes to synthesize its own proteins. It's hijacking the system. This is a smart organism. It's able to use our own stuff to attack our own body. So now we are converting that mRNA into a protein, and this protein is going to be maybe the part of the capsid for a future viral progeny. Okay, so eventually our own cell is going to assemble a bunch of viral babies, and now these viral babies can go out and infect other cells. Okay, so that is the process. When we talk about double-stranded DNA viruses, they are going to use our own machinery to synthesize its own progeny. It doesn't need any of its own enzymes, right? Double-stranded DNA is something our bodies are used to seeing. Been looking at it since we were babies, right? Whenever our nucleus sees double-stranded DNA, it says, hey, I know you. I'm going to use my DNA-dependent DNA polymerase to transcribe your code into an mRNA. That mRNA is going to go into the cytosol and be translated into proteins. Those proteins are going to assemble a new virus. That virus is going to burst the cell eventually and go on and infect other cells. Okay? So that's the relevance. Whenever we talk about double-stranded DNA, I want you to think about that. Now, what is the relevance of naked? Well, there's two types of viruses. I'm sure you can guess by now. If one type is naked, the other type is enveloped. Enveloped, okay? And so a naked virus, well, let's talk about envelope. Envelope viruses have a capsid just like all other viruses, but they're going to be enveloped with a almost like a phospholipid membrane. Okay, so just like our cells have on the outside of it, envelope viruses have this nice enclosed membrane on the outside of them. Okay, now when it comes to naked versus enveloped, there's benefits to each. For naked viruses, what's nice about a naked virus is that since it doesn't have this envelope, it doesn't need an envelope. So if a adenovirus, say someone has this upper respiratory tract infection, they sneeze, a little bit of naked virus lands on the table, because it doesn't require any envelope, it doesn't require fluid to be around it. So that virus can dry out on the table and still be an infectious agent. Versus an envelope virus always needs to be in some sort of fluid. So whether it's a respiratory secretion, whether it's a fecal type transmission, any of these types of viruses, if they are enveloped, then they require some sort of medium. Okay? All right, so that is the relevance of naked, is that it can live on fomites, or it can live on sort of the objects in our environment. That's what a fomite is. Fomite just means an inanimate object, and it does not require it to be some sort of aqueous medium. Okay, it can live just on a dry surface. Great, so let's continue on here. Reservoir is going to be humans, and it's going to be transmitted through respiratory droplets. It lives on fomites. Someone can sneeze into their hand, touch a doorknob, that doorknob can dry out, and it's still alive there, okay, and can still infect the next person. In terms of diagnosis, you can detect this antigen of adenovirus. For the most part, we're not going to bother with trying to diagnose this through lab work. This is just such a common virus that antigen detection, yes, is a possible way, but it's not really necessary. Big things here. As a sort of rule of thumb, when you have viral infections, you don't see exudate. You don't see exudate. What is exudate except when you have say a neutrophil. Neutrophils have a lot of toxic chemicals inside to destroy bacteria. Neutrophils will gobble up a bacteria, release this, essentially what it is HOCl, which is chlorine, right? It's going to release that, bleach. It's essentially bleach. So it's going to release the bleach onto a bacteria, destroy that bacteria, and then all of the debris is going to be released out into the milieu. So as a neutrophil destroys bacteria, it's going to release a bunch of pus, okay? As it destroys bacteria, it's going to release pus. This pus is what we call exudate, and that is due to breakdown of bacteria. Now, when it comes to fighting viruses, neutrophils don't really have a job to do. Neutrophils cannot gobble up viruses, okay? To fight viruses, we really need our T cells and our macrophages, all right? So neutrophils don't really play a part. And so when it comes to viral infections, as a rule of thumb, we don't see exudate. There are exceptions, but as a rule of thumb, we don't see exudate. What we look for instead is just erythema inside of the throat. We can look for a watery, sticky, conjunctival exudate. So you can see in the conjunctiva of this gentleman a lot of liquidy material building up. Okay, this is a self-limiting infection and will go away on its own. For our Coxsackie virus, now instead of having a double-stranded DNA, here we have single-stranded RNA. Okay, so this is a bit different. If our virus contains a single-stranded RNA that is positive, does it need to go to the nucleus? If we have a strand of RNA, a positive strand.
Sorry.
No problem.
Are you asking, or you were?
Sure, yeah. What do you think?
No, I did not, because I hear that you were like waiting. I said I did not understand.
Oh, okay, no problem.
We're asking or not.
Yes, so we have double-stranded DNA. We said that has to go to the nucleus because double-stranded DNA in the cytosol, it's just going to get broken down by enzymes, right? Our cells are not used to seeing DNA in the cytosol. That's something that's abnormal. So if a human cell sees DNA in the cytosol, it's going to say, whoa, 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 something's wrong here. DNA belongs in the nucleus. It shouldn't be in the cytosol. I'm going to break that down. And that's why it's so important for double-stranded DNA to go right to the nucleus that we described here. Double-stranded DNA goes to the nucleus, where nucleus is very comfortable seeing double-stranded DNA. That's what our own chromosomes are made of. We've been seeing that since we were babies, and so it's able to manifest an infection by going to the nucleus. Now, when we have single-stranded RNA, that's a positive strand. This positive essentially means that our single-stranded RNA looks like mRNA. It looks like mRNA. Okay, now, our cells are very used to seeing mRNA. And so when this single-stranded RNA enters the cytosol, I'm going to draw a new cell here with a new virus on the outside. When this strand of single-stranded RNA that looks like mRNA gets in the cytosol, the ribosomes are going to bind onto it immediately. We're going to have ribosomes binding onto that saying, oh, you're mRNA, you're where you need to be, you're in the cytosol, I'm going to convert your code into a protein. Okay? Now, if we're creating, if we have a piece of mRNA, we still need to make more mRNA. And there's nothing in a human cytosol that can convert an mRNA to mRNA, right? Because this virus wants to make more of its genetic code. So, our bodies are not used to converting RNA into RNA. We don't do that. We convert DNA into RNA. We convert DNA into DNA. But we don't convert RNA into more RNA. So one of the first things that this virus has to synthesize, one of the first proteins, is an RNA-dependent RNA polymerase. Okay, an enzyme that can take RNA and convert it into RNA. Okay, so when we talked about DNA viruses, we said it doesn't depend on its own enzymes. It can depend on all host enzymes. However, RNA viruses need to synthesize their own enzymes in order to continue manifesting an infection, creating more progeny. Because we have nothing in our body that can convert RNA into more RNA. It needs to synthesize an enzyme that knows how to do that. Okay? And so that is our big difference between double-stranded DNA viruses and single-stranded DNA viruses and our mRNA viruses, or our single-stranded RNA viruses, is that DNA viruses do not need to rely on their own machinery. They do not need to rely on their own enzymes. We have everything in our bodies that they need to manifest an infection. Versus RNA viruses, which must create something that can convert RNA into more RNA. We don't have that in our bodies. They rely on their own enzymes. That is the biggest difference, and that is something that you will be asked about and is sort of core to your understanding of these different viruses and virology. Okay? Great. So moving right along here, for Coxsackie virus. Now let me erase some of this stuff. We're starting to collect too much stuff on this slide. Okay, great. So, Coxsackie virus, the reservoir is humans. This is fecal oral transmission, okay? So we're thinking infants and young children. We do not see exudate. This is a virus, so that makes sense. There's no neutrophils involved here. What we look for are vesicles and ulcers on the posterior oropharynx. You can see in the image here all of these kind of looking like vesicles. It looks a bit like herpes, actually. And so what we call it is herpangina, painful, herpetic-looking lesions, okay? These are vesicles, and these are on the posterior oropharynx. It's called herpangina, okay? So that's sort of the special thing about Coxsackie that you should know going into it. Know what the family is in terms of single-stranded RNA. It's part of the Picornaviridae family, and it is a naked virus. Great. So, strep pyogenes, group A strep, common in children. This is a gram-positive cocci that presents in chains. And in terms of knowing that it's a coccus and that it's in chains, always look back at the name. I'm sure you're comfortable with this, but a strip of coccus, a chain of cocci, strip of coccus, streptococcus is just a chain of cocci. Okay. So here the transmission is going to be respiratory droplets. How do we diagnose it? It is beta hemolytic, meaning when we grow this particular bacteria in an agar plate with blood in it, it causes a lot of hemolysis. Okay, sort of the grades of hemolysis go from beta hemolytic is the most hemolysis, alpha hemolytic is a little bit of hemolysis, and then gamma hemolytic is very little hemolysis. Okay, so when you have a lot of hemolysis, we call that beta hemolytic, and that is an easy way to sort of diagnose these particular organisms. Catalase negative, it cannot break down certain types of proteins. There's these anti-ASO antibodies that our bodies make in response to strep pyogenes, so that's a good way of diagnosing it. Lancefield A is another way of diagnosing it. That's how we get our group A strep. We call it group A strep because of this Lancefield A, and this basically just means there's a certain protein on the surface of the bacteria that we call the Lancefield A. Okay? It is sensitive to a certain antibiotic called bacitracin. Now, when we look in terms of our clinical indicators, exudate is a big part of the picture here. It's a bacteria. We're going to have neutrophils. We're going to have a lot of destruction, so exudate makes sense. Look for petechiae in the pharynx. Okay, a lot of people will call it like a strawberry pharynx. You can see all of these little spots and petechiae in the back of the pharynx. Why do we have petechiae? Well, we said there's beta hemolysis, so it's probably breaking down a lot of the red blood cells and platelets that are coming into the area, giving that petechiae. High fever is important. No treatment can lead to acute rheumatic fever. Okay? And so how do we treat? We're going to give beta-lactams, anything, think in the penicillin line of antibiotics. One of those are going to be your answer choice. Long-term after the infection, we can present with that post-streptococcal glomerulonephritis, immune complexes presenting as brown urine. This is due to the M protein on the capsule of strep pyogenes. Okay? Great. Now, when it comes to acute rheumatic fever, Eva, just give me one symptom of acute rheumatic fever. We talked about this. I can't believe that we have been together almost 8 weeks, but it has been almost 2 months since we did our cardiology lecture, and we talked about acute rheumatic fever. So I want to make sure that this stuff is staying fresh in your mind. Give me one symptom of acute rheumatic fever.
Murmur?
Murmur, yes, that's the one I was looking for. I thought you were going to tell me fever, and I was just going to end.
No, you're asking about cardiology, so I said, okay, let me see which one I can say first.
Good choice, very good choice. So murmur, and you get bonus points if you can tell me a valve. Give me a valve. Eva. Yes, murmur of the mitral valve. Okay, and so for whatever reason, this acute rheumatic fever tends to involve the mitral valve more than any other valve. Aortic valve would be number 2 if we wanted to give a number 2. Okay, and this is going to be a systolic murmur. It's going to be a regurgitation type murmur. Okay, when we have our acute rheumatic fever, what's happening is our own immune system is attacking the valve. Okay, never forget that. This is not a bacterial infection of the valve. This is our own immune system attacking our valve with acute rheumatic fever. And when we have that acute rheumatic fever, it's going to cause a weakness of that valve, giving us regurgitation, a systolic murmur. Okay? Now, for patients that had this acute rheumatic fever, never got treatment, this is not a deadly condition. Patients can live on. They can live into their 50s and 60s. However, they are going to present with a chronic rheumatic fever, which is instead of having a mitral valve regurgitation, for chronic, we're going to have mitral valve stenosis. Okay? So with mitral valve stenosis, now the valve is not opening enough during diastole. So we're going to look for that diastolic murmur of blood flowing through that valve that became stenotic because of this history of acute rheumatic fever. Okay? Great. So those are the 2 important long-term sequelae we need to consider for strep pyogenes. All right? Fusobacterium, this is more rare, not as high yield. I guess the most important thing here you can look for is this no exudate with this particular bacterium. This bacteria loves to infect the tonsillar pillars, and right behind the tonsillar pillar is going to be our jugular vein. And so as this bacteria starts to cause this necrotic damage of our tonsil, it can actually necrose all the way into the jugular vein and start causing clots and thrombi in the jugular vein. Those clots can actually travel north up into the brain and cause this enlargement of jugular vein and cause strokes and all this kind of stuff. It's called Lemierre syndrome. This one's not terribly high yield. Don't worry too much about this one. Same thing about this Arcanobacterium. It's just another way of having exudate and pseudomembrane. This one is going to be associated with a rash on the trunk and extremities, however. Okay? All right, so sort of our introduction to pharyngitis. 2 more causes of pharyngitis that were very important, so important that we actually vaccinate against them. So, Corynebacterium diphtheriae causing our diphtheria. This is a gram-positive pleomorphic bacilli, meaning that sometimes it can stain gram-positive, sometimes it can stain gram-negative, and it has a very peculiar shape, okay? But it is considered a bacilli. The reservoir is going to be the upper respiratory tract, also the GI tract, and unvaccinated people, right? Look for that history of parents who are anti-vaxxers, okay? Virulence factor, very important for diphtheria, okay? I'm putting 2 stars here. This is very important. Diphtheria toxin is an AB exotoxin. When we say AB exotoxin, essentially it's a toxin with 2 parts, right? AB makes sense. So our A part is going to be for binding to cells. B part is going to be for causing the damage. Okay? So whenever we have these AB exotoxins, it's an exotoxin, meaning it's actively secreted from the bacteria, and it has 2 parts. 1 part binds, 1 part causes the damage. On a lysogenic phage, lysogenic phage means that, in terms of bacterial DNA, without getting too much into the weeds here, all bacterial DNA is going to be on a single circular string of DNA. Okay, this is unlike human DNA, where it's a long chain, not a circle. However, as bacteria go through life, sometimes viruses actually will bind to a bacteria, just like they bind to our cells, and they will inject some of their own DNA, okay? And we call this a lysogenic phage. Now, when this bacteria goes on to multiply, it's actually going to carry some of that viral DNA along with it, okay? It's going to be separate from the bacterial DNA, but it will be carried along with it for extended periods of time. Okay, so this lysogenic phage in the context of diphtheria carries that diphtheria toxin. Meaning, if somehow, for some reason, this bacteria lost the phage, maybe when it went on to multiply and create its babies, it didn't copy that part over, this diphtheria bacteria would not have that toxin on it. It would not be able to cause damage in our system, okay? And so this idea of a lysogenic phage is important because you can have a diphtheria bacteria that is not going to manifest with any pathology. You can have a diphtheria infection without having all of the pseudomembranes and things we're going to talk about. And so why is that? Because of this lysogenic phage. It's carried separate from the bacterial DNA, but it is carried through the generations of bacteria. How it works is very important as well. It's going to work via ADP ribosylation of EF2, which is one of the important proteins for ribosomal translation, right? So when we have a piece of mRNA, we're going to have a 30S ribosome and a 60S ribosome bind to that mRNA, and it's going to start synthesizing proteins in a long chain. Now, in order for this ribosome to do its job, it needs some of these extra factors. EF2 is one of the extra factors. In order for the ribosome to know to continue forward, it needs these factors. If the diphtheria toxin inhibits this protein synthesis via ADP ribosylation, this whole process cannot occur. We cannot synthesize proteins. Now, if a human cell cannot synthesize proteins, you're going to have a bad time. This is going to be a big problem. Humans need to constantly be synthesizing proteins, and so loss of the ability to do this is going to have a lot of big problems for our human cells. Okay. Another important point, less important than the other two, is that there is a requirement for iron. These bacteria are dependent on iron, and so they can only cause all of these effects in the human body if iron is present. Okay, and so we think about, when we did our hematology lecture, we talked about hepcidin and how hepcidin causes sequestration of iron and it prevents the human body from absorbing iron. And we talked about how that has an evolutionary important role because a lot of bacteria are dependent on iron. Here's a perfect example, right? We need to be able to cross-connect these different topic areas because that's what the exam is going to want you to do. So if hepcidin is able to work effectively, it can actually stop a diphtheria infection. Why? Diphtheria needs iron to be able to synthesize these deadly proteins, these deadly toxins. If there's no iron present, diphtheria will not synthesize the toxin. Okay? Great. So how do we diagnose this? There's something called tellurite agar with cysteine inside, and it grows gray to black colonies on this. There's really no other time we're going to talk about tellurite agar, so memorize this particular agar in the context of diphtheria. Okay. ELEC toxin is another way to diagnose this. Clinical indicators and complications, so we can have this pseudomembrane formation in the pharynx, where we'll see neutrophils, necrotic epithelial cells, bacteria, fibrin, all this really nasty tissue accumulating in the pharynx, which can lead to occlusion of that respiratory tract, rapid difficulty breathing, cervical lymphadenopathy, giving you this bull's neck appearance, this really thickened neck, and a fever. Okay. Diphtheria can also go on to involve the heart, causing a myocarditis, arrhythmias. Typically, you're not going to be asked about this particular stuff. You really need to know about this pharyngitis, pseudomembranes that can lead to respiratory tract occlusion. Okay? And so, obviously, the vaccine is going to be very important for preventing this. If we have an active infection, we need to give antitoxin to block that AB exotoxin, and respiratory support. Okay? Great. And so we're going to stop there for today. Next time, we're going to move into our mumps virus and keep moving through our respiratory tract and talk about all of these different lower respiratory tract infections, pneumonias, UTIs, and urogenital infections. Okay? This is overall a pretty quick lecture, and so we'll be able to move through that quickly when we meet next time, which I believe is after the Thanksgiving break, right?
Mm-hmm.
Yes.
Monday, no?
So our next lecture together would be after the Thanksgiving break, I believe. What do you have written down?
It was a Monday. Let me go to the, because I was checking before.
Yes.
Looking a little bit. Ah, it's open. Oh, great. I leave it open. Okay, the second, 12:30.
On the 2nd at 12:30, we were doing Micro 2.
And then Thursday at 10:30. Why is 10:30 and 2:30? I don't know. Maybe it was something that we had to discuss.
Oh, really? Maybe I made a mistake. Okay.
10:30, yeah. Let me see. Yeah, it said 10:30.
You know what? I think it may be because I have to fly.
I think you have something or...
Yes. I have to fly to Iowa on that day. And so, yeah, we'll have to figure out what we're doing for that particular lecture, but we'll figure it out.
I put it in the chat.
You put it in the chat? Yes. Yeah, that's always helpful when you put that.
Yeah.
Okay,
I
good.
did.
Good, thank you very much. 10:30, probably that's supposed to say 12:30, and we'll do biostats. Good. And then we're also going to do one extra lecture. We're going to do 2 hours of questions together.
7, I think you said.
Yes, on that Saturday. Possibly Saturday, possibly the Sunday. We'll talk as we get closer what day we're actually going to do that.
Okay,
Okie dokie.
perfect.
Great, Eva. So, have a great Thanksgiving break. Do lots of questions. Please email me at least once or twice during the break any questions that you have, okay? This is not a break for you to take a break from studying just because we're not meeting. You should be studying. So you and Toby, if you're hearing this, please give me an email. I want at least one email from you guys over the break with some question that you need help with, okay? And I will email you back. I always respond. Even if I have a plate of turkey and pumpkin pie in front of me, I promise I will respond to you, okay?
Okay, so see you next time after Thanksgiving.
Okay, great. Have a
And
great...
happy Thanksgiving
Yeah.
for both of you if Toby is going to listen to this.
Thank you, Eva, and we will see you soon, okay? Take care. Bye-bye.